Clark. Most of you know me. Today I'm going to be giving a lecture over TBIs. So basically going ahead and starting it off, what is a TBI? A lot of this is going to be a review, but I think it's important to go over. So traumatic brain injury, it's just any traumatic event that causes injury to the brain. The article that I found here split it into mild, moderate, and severe. I think this is a good guide, although it's definitely going to depend on how our patients presented to us in the field, um, you know, our decisions that we make and different things like that. But at least this gives us an idea of things to look out for and to kind of put our patient into a category and decide, how aggressive we need to be with our treatment and also how aggressive we need to be and how quick we need to move with patient extrication. So here's that. Basically, mild starts off their loss of consciousness, GCS, and their amnesia about the event. And then you get all the way to severe, loss of consciousness greater than 24 hours with a low GCS. And that's when you start looking, for really outward symptoms, seizures and other things like that. When might we see a TBI in the wilderness setting? Well, actually, it's fairly common. The article I found states that 5 to 50% of the wilderness injuries result in TBIs. Um, Most of that being, falls during mountaineering activities, or, there's other activities that include skiing, snowboarding, diving, cycling, hunting. Anytime you're out in the wilderness, you're putting yourself at more risk, not only for injuries, but also just because there's limited resources available if you do get hurt. So, looking at anatomic injuries. So, these are possible things that could be going wrong internally with the patient that are leading us to think, okay, there's a brain injury, and what our treatment's going to be. Not necessarily that our treatment, you know, at the time we're going to be like, oh, I think this is a subarachnoid, so this is going to alter my treatment. But it will, it gives us an idea of what we think, might be going on underneath. But our patient, ultimately, we're going to treat the patient and, do what they need specifically in that time. We have subarachnoid, subdural, epidural, cerebral contusion, diffuse axonal injuries. You can kind of see on this image over here, just a quick representation of how it's going to be affecting the person's head internally. A couple things to keep in mind, subdurals are going to take a little bit longer to grow and develop. So if there is a mechanism that you're suspecting a head injury, but there's no outward signs yet, keep an eye out for your patient. Any deterioration that they might have, that's something to look, keep an eye out for, constantly reassess them, even though they might seem stable. You want to be reassessing their neurologic status. Um, Epidurals, that's our classic walking, talking dead, keep an eye out for that. As far as cerebral contusion and diffuse axonal injuries, mechanisms for that is, that, um, you know, coup contra coup, the friction inside the brain, against the wall. It's you can see here the diffuse axonal injury. It's injuries due to that friction. Um, so yeah, just some things to keep in mind. As far as signs and symptoms go, I put Cushing's triad up there. Um, it's kind of the thing we're all looking for and thinking about. You think TBI, you're like, oh, well, what about Cushing's triad and herniation? So I put this up there to keep in mind. This is a review for us, but hypertension, bradycardia, and irregular respirations. I also put on there agonal. They can be agonal at times. The hypertension, some literature that I was looking at states that it's widening pulse pressures is can be a sign for in herniation. That's something that they're also looking out for. But for us, I think Cushing's triad is a great way to see, oh yeah, okay, so we got some impending herniation going on. Kind of judge that with our patient. As far as other things, increased ICP. Normal is 5 to 15 millimeters of mercury. Um, I mean, this isn't something you'll outwardly see, but is, something to keep in mind if you do have a, butterfly ultrasound or any ultrasound device to do an ocular test. You can get an idea of that, or just outward signs in the patient. Um, Seizures, very common. Paresthesia, certain deficits that the patient's alert enough, you can, if they have certain neuropathies or tingling or numbness or anything like that. Emesis, common, watch out for that. That's an airway concern. Loss of consciousness, overall level of consciousness, altered mental status, and GCS changes. Um, with that being said, GCS changes, you have their motor function, posturing, different things like that in account too. So things to look for. As far as diagnostic tools go, we are usually somewhat limited in the backcountry setting, but if you have it, consistent heart rate monitoring. I mean, if you have a cardiac monitor, it's great to put them on there, but I mean, how often do we have that? Blood pressure, respirations rate, and um, if they're irregular or anything like that. And then pupils, um, pupil signs, um, if they're different from one another, varying in size, sluggish, different things like that. If they, um, there is a thing to keep in mind with lateralizing signs in pupils that can be a sign of a traumatic brain injury. We won't go into it, but they're depending on the pupil response, there's a you can gauge where certain things are going on. Ultrasound, I talked about that a little bit earlier, and we all have learned about it a bit, is the butterfly that we use, and using ultrasound to do an ocular test and get an idea of the intracranial pressure, the GCS, and alert and orientation, alert and oriented. You can gauge how your patient's doing initially and consistently reassessing that and kind of trend where your patient's going, if they're getting better or worse. And that's a helpful, how much more aggressive do you need to be? Do you need to do more treatment? Do you need to get them out of there quickly? Things like that. So I know that for us, we have our own specific treatment protocols, and I think that basically I just wanted to give a treatment that I gathered from different articles, new up to date medical treatments for TBIs. And this kind of gives us things to think about, how our treatment compares to other treatment and things like that. So, starting off, keep in mind that where there's TBIs and head injuries, we also have to think about spinal injuries, cervical spine, and what kind of mechanism was that, and other injuries too, don't we got to think about distracting injuries and things like that. So be careful, moving your patient is difficult in the wilderness setting, but that's something to think about. Level of consciousness and GCS, good to get an idea of where your patient's at right at the time of the incident, and then continue to trend that throughout your treatment. ABCs, this is things we're all thinking of all the time. So as providers, so the airway considerations, how aggressive do you need to be with the airway? Are there respirations? Are they apneic? Are they irregular? Are they not setting? Are they, what's going on? So you may have to have a definitive airway. You may need to intubate if you have that capability, or put an advanced airway in at any time. And then other airway concerns, we were talking about the emesis, so be aware of that as far as, packaging and keeping them on their side, or different things like that. Vitals monitoring, if possible, we got to use what we have out there. And if you're not responding as a provider and you're just out there, that's another situation in itself. Um, and total CO2 is good to keep it between 35 and 40 unless there are signs of impending herniation. We want to keep a map of greater than 60, a systolic of greater than 100, respirations right around 12. Or one thing I noted is that the article I was reading, the Otten and Dorlac, is if you don't have a way to monitor capnography and there are signs of impending herniation, they say that keeping their respirations right around 16, if you're providing respirations, kind of helps. That's a good um, rate to keep them at if you're trying to keep it between 30 and 35 for the end tidal, and kind of keep that is where you're hyperventilating at for that impending herniation. As far as SpO2 goes, I think 94 to 99, we don't want to over oxygenate them, but at the same, and we don't want them to be hypoxic. We want to keep an eye out for secondary brain injuries, so we want to, monitor their oxygen, but at the same time, that's something that's difficult to keep an eye on. We basically, mostly don't want them to be hypoxic. Um, if you I just threw this in here, but I mean, we want to try to attempt to keep a normal intracranial pressure, a normal MAP, and a cerebral perfusion pressure of greater than 60. But, that's getting into some critical care wilderness medicine, and that's difficult to keep an eye on consistently. So, um, yeah, I mean, do the best you can. A side note on that, to calculate cerebral perfusion pressure, you just take the map and subtract the ICP. So something to note. But normothermia, it's, initially if you're in a cold environment, it's easier for the patient um, uh, to be hypothermic. So you want to keep them warm, um, and that's your initial treatment, but you don't want the patient in these circumstances to be hyperthermic. There's good evidence to show that if you have a patient with a TBI and you have them hyperthermic, that can actually worsen the TBI. So keep an eye out for that. Hypertonic saline, it's a good way to relieve the pressure, decrease your ICP. When I was reading some of the literature I was looking at, stated that hypertonic salines used more often than mannitol. Um, Not necessarily, they weren't saying anything that it's like better or worse specifically, but they did say that mannitol in the wilderness for packaging purposes, it's more difficult. So, I mean, at that point, you got to use what your protocols and what your services have. So, I know we like hypertonic saline, and I've heard a lot of good things about that. So that's something to think about. Hyperventilation, when we need to, you want to keep your patient pretty normal, other than if there are, outward signs of impending herniation. We got Cushing's triad or different things like that. So packaging, um, on the side, if there's emesis, a lot of literature, everything I read, the big thing coming up is consider head position at a 30-degree angle. It's it was the reason for that is it leads uh, jugular vein distension. It's like draining. It wants the so that I mean, there's more research going into that, but I think that's something for us to consider. And yeah, that might be beneficial to the patient, but it's also, how difficult is that going to be to keep them in a specific position? How are we extricating them? Do we have a litter, or are they going to have a helicopter? Then it might be more useful there. Are we trying to carry them out on some sort of makeshift? It just kind of depends. So it's situation dependent, I think. Evacuation, going back to that chart um, that I was talking about, or not chart specifically, we're going to look at that next, but the mild, moderate to severe TBI, that's a good way to gauge, I think, how quickly you need to extract your patient. And actually, if I go on to the next slide, this is a screenshot I just took off of the article from Otten and Dorlac, and this is actually based off of the TCCC guidelines, I believe, for TBIs. But I think it's a good chart to look at because, initially it's the treatment that is within our scope, and, we're obviously, it's a classic. Is a scene safe, yes or no? Looking at it, we're going to do our, uh, level of consciousness, our ABCs, monitoring. and then we're going to reevaluate. We're looking at our vitals, so we're getting an idea of how the patient's presenting, and then you're looking, okay, is our GCS normalized? Yes. Okay, ground evacuation? No. Then okay, that's going to lead us more towards an urgent evacuation, hopefully by air if we have the resources available. If they're unresponsive, you do your airway, you assess our pupils. If there's imminent signs of impending herniation, you got your hypertonic saline, you can hyperventilate. And then obviously that shows that they're a lot worse. You're going to have to do more urgent evacuation. So I think this chart towards the end there helps us, gauge how aggressive we need to be and how quickly we need to extricate the patient. I think that's something to keep in mind because it's nice to have it in the back of your head. Okay, I think if the patient gets more, you know, trends more, downward in this way, I want to extricate soon, or they're like, oh crap, we need to get out of here. I do think it's good to constantly be reassessing your patient and always have a backup plan for extrication, even if they're okay right now. Something may change, they may get worse, and so I think it's a good idea to have a backup plan when treating your patient. So. Packaging and transport, things to consider. Of course, this is very situation dependent, but just some things to consider here. Rescuer safety, that we've talked about that before. If we go in and, someone gets hurt that we're with, we have to make sure that we're safe in rescuing them because if we get hurt, then we become another patient and then more resources have to come after us. And then if we can't help, we can't help the patient if we're hurt. So that's the big one. Patient condition and severity of injuries, like we were talking about earlier. How bad is the patient? Will they get worse? Kind of thinking about things and how you're going to move forward with a plan for extraction. Resources available, how are your communications? Do you have somewhere that's responding out to you? Is it by ground? Is it by air? Just taking different things to an account. If you are going to be the one extracting the patient, it's what's the weather like? What are we bringing in? What material? What do we need for this rescue? And then also terrain. We're talking about what's the best play. Just kind of things to think about when planning a rescue overall. These are the sources I have. They were pretty helpful. If you click on the link, they're not bad articles to read. A little bit more in depth on some of the things that I said, but it gets into more um, stuff that's out of the paramedic scope somewhat, and then some of it, is very useful. So read into those, and if you have any questions or want to talk about any of it, you can email me, or if you have my number, I'm happy to look extra stuff up or just talk about it. So that's all I have. Oh, another keynote I was going to add is that I recently read that ketamine is no longer contraindicated in patients with suspected TBIs. So, as far as pain management goes, that's pretty sweet as another alternative to narcotics. So, all right, that's it, and thanks for listening.